All right, guys, I think I'm going to go ahead and start. Um, I'm Dr. Pantea Sharifi Hannauer. I'm a child neurologist. I'm also the medical director at Pediatric Minds. We offer an intensive day treatment program for children ages 22 months to 7 years with neurodevelopmental disorders. I'm also part-time faculty at UCLA, Mattel Children's Hospital, part of the child neurology department. I wanted to thank you for all being here. These are really, really crazy times, and it's very strange for me to be doing this via Zoom and not be able to look at people directly. So, but I know that this is being recorded, and I think it'll be available on the Epilepsy Expo website for you guys to share with people and friends if you wish. Okay, so today I'm going to talk about the epilepsy and autism link. We definitely know that there's a connection between the two. And so we're going to first discuss what the relationship is between the two, what the risk factors are involved in both of those, the syndromes, the common syndromes in which both are present. We'll quickly talk about some comorbidities, coexisting problems that occur in both. And we're going to talk about epileptiform abnormalities on EEG and some future goals in research. So we definitely know that autism and epilepsy are related. Kids with autism have a much higher rate of epilepsy, and patients with epilepsy have a much higher rate of autism. So 40% of kids with autism have epilepsy compared to 1% of the general population. And there's also an increased risk of autism in the epilepsy population. And all of the epilepsy population, there is at least 6% of them that have autism compared to 1.4% of the general population that have epilepsy or seizures. So definitely there's a higher risk for both in each of those compared to the general population. So, and more support that even the presence of autism can increase your risk of epilepsy, and even your presence of epilepsy can increase your risk of autism. So there's a big study that looked at the prevalence of epilepsy in families who have more than one autistic child. And the presence of epilepsy in those children were about 13% compared to only 2% when you looked at families that only had one autistic child. So the more autism you have, the more likely you're going to have epilepsy. And also when they looked at the unaffected siblings in the families with multiple kids that have autism, so if they have 3 kids, 2 of them have autism, 1 of them doesn't, the risk of epilepsy even in that sibling that's unaffected is higher. So there's definitely something going on there. And again, remember, the risk of epilepsy in the general population is only about 1%. So what do they have in common? So they also have a lot of commonalities. Well, they both can be associated with cognitive impairment, intellectual disability. They both are associated with social cognitive impairment, which is one of the hallmarks of autism. They both can have common underlying genetics or gene mutations or syndromes. They both can have a common underlying mechanism or pathophysiology. And they both can have very similar comorbidities. ADHD, anxiety, learning disabilities are common in both autism and in epilepsy patients. So in order to really understand what the relationship is, it's critical to really understand what each disorder is. So we know that autism is a spectrum disorder. It is a neurodevelopmental disorder known to have many different underlying causes or etiologies. It's a diagnosis based on behavior manifestations or phenotype. And the hallmark is the presence of social communication, social affect, or basically social cognition deficits, as well as the presence of repetitive behaviors and restricted interests. It has to be there before the age of 3. You cannot catch autism. You cannot get it through a virus or a vaccine. It's there from the beginning. And the prevalence of autism is 1 in 68 or 1.4%. And it is a spectrum disorder. And what does a spectrum disorder mean? It means that there's many different etiologies, there's different severity of symptoms and different comorbid conditions associated with it. And because of the spectrum, it strongly impacts quality of life, long-term independence, and it creates a big burden on society. So I want to focus a little bit about social cognitive issues and social cognition in autism. So that's the biggest hallmark of autism, is a social cognition deficit with the repetitive tendencies and the fixation. So what is social cognition? Usually we talk about intelligence or intellectual cognition, but no one really talks about social cognition. And social cognition is the ability to process, remember, and use information in our social environment to help explain our own behaviors and to help explain the behaviors of others, to understand them better. And in order to be able to do that, you have to pick up on social signals, or social cues, we call them. You have to be able to process that information. And some social cues are facial expressions, your eyes gaze, deviation, social referencing, reading body language. And our social cognition then helps us know how to respond to the actions of others, helps us become more sensitive to psychological state of others, how other people are feeling. And then it allows us to engage in what we call pro-social behaviors, like cooperate or share or give empathy. And it helps us adapt and adopt to the perspective of others. So it helps in perspective taking. So two main parts of social cognition that's often studied is empathy and theory of mind. And empathy is the ability to understand someone else's emotional state, which is the definition of sympathy. So sympathy is the ability to understand someone else's emotional state. But empathy takes it a step further, where you can match that emotional state to yourself. So you can feel the same as they can feel. Okay? That's empathy. And the other big aspect of social cognition is theory of mind. And theory of mind allows you to put yourself in someone else's situation and look at that situation, and look at whatever shared situation is going on from a different point of view or perspective. So it helps you in perspective taking. These are the two huge things of social development that are missing in autism. Okay, so of note, in a lot of MRI studies, this actually has been mapped out to different parts of the brain in autism, specifically in the temporal lobe, which we also know is a very significant area of the brain that's predisposed to seizures. So now we're going to talk about understanding epilepsy. So epilepsy is defined as having 2 or more unprovoked seizures. The frequency of it in the general population is about 1%. And the ILAE, which is International League Against Epilepsy, classifies it based on there's something causing the epilepsy. Now, it is no longer unknown or idiopathic. We have come to understand that there's always something underlying the epilepsy. We may not know what that is, and there's still an unknown category, but there's something causing it. It could be genetic, it could be structural, like a malformation or a lesion or a tumor. It could be metabolic, like a metabolic disorder or electrolyte imbalances. It could be immune modulated, like an autoimmune disorder. It could be infectious, like an encephalitis, or we have the unknown category. The cool thing is that, over the last 10 years, finally, we have learned that epilepsy is also considered a spectrum disorder because it has a very wide range of underlying causes, similar to autism. It can have a wide range of seizure severity and different seizure types, so it can present very differently. And it can have a wide range of differing comorbidities or coexisting problems. And it can have a wide range of how it impacts education, academics, independent living, etc. So it also causes a big burden on individuals and society as a whole. So that's another commonality between autism and epilepsy. Now, it is very well established that epilepsy has a huge impact on intellectual cognition or cognitive functioning. This has been something that's been studied for years and years and years. And of note, one of the articles I like to always allude to was an article that specifically looks at the impact of especially ongoing seizures in epilepsy, meaning seizures that are refractory, on IQ points. And Anne Berg et al. Looked at a population of kids in 2012 and found that when they looked at children who had epilepsy onset before the age of 8 and they followed these kids out for another 8 to 9 years, and they tracked their intelligence and IQ, and there was an 11-point drop in their IQ. So we definitely know that epilepsy can impact cognitive skills. We also know and have learned that early onset seizures early in life can have a broader impact on cognition, and refractory or uncontrolled seizures can have a broader impact on cognition, and those are often what lead to the epileptic encephalopathies, and we'll talk about those in a little bit. And even in settings where there isn't a huge drop in IQ, let's say that epilepsy severity or burden is really high for a while, and then it's controlled for a while, and then it gets out of control again. Even in those situations, whenever that happens, development slows down or there's actual regression in development. So we definitely know cognitive skills are impacted in epilepsy. Now, nobody again had really focused on social cognition or social cognitive skills until about the last 10 years. And there's been a huge explosion of studies looking at the impact of epilepsy on social cognition. So we know that they can definitely experience social cognitive deficits or impairment. And this can even occur right at the time of the first seizure, depending on what age the seizure is, or even it can predate the onset of the first seizure. And we also know that social cognition is impacted earlier in epilepsy, even before the full-blown symptoms of autism develop. So you can have social cognitive delays or deficits and not quite meet criteria for autism right away. So we definitely know that there's some social cognitive impact. And social cognition can be impacted mildly or severely, regardless of your IQ. And we see that this is possible. Like in autism, you can have high functioning autism where the kid's IQ is really high, but they have very severe form of social cognition deficit. So the same thing goes with epilepsy and your IQ. And we know from more recent research that epilepsy itself can definitely impact and reduce your information processing speed. Remember we talked about how our social cognition depends on picking up or processing social cues. Well, that can definitely reduce the rate of that. Epilepsy can cause attentional issues. Epilepsy definitely can impact executive skills and executive functioning skills, which are all have been shown to be the case, and we know those directly impact your social cognitive skills. And more specifically, there's been a lot of studies on temporal lobe epilepsy, and because that's the area where a lot of emotional memories and social emotional recognition occurs, but there's definitely social emotional impairment in people who have temporal lobe epilepsies. So epilepsy again is also a spectrum like autism is, and the goal of the reason that's important is because it kind of changes the goal of treatment, right? When you go to your epileptologist or your epilepsy center, the goal of treatment should not just be aiming for stopping the seizures, but it should be stopping the seizures and managing other neurological consequences of that, but really to also improve cognitive and social emotional outcome or social cognitive outcome, which will then allow you to help manage psychological issues, social consequences. So it's really, really important that part of epilepsy care is to also identify the presence of social cognitive deficits and if there's autism or not, because it makes a difference in terms of long-term prognosis and development. Okay, so now there's risk factors associated with both. So this is something else that epilepsy and autism have in common. We definitely know that the presence of intellectual disability or lower IQ increases the risk of both. We know that early onset life seizures, as we see in epileptic encephalopathies, increases the risk of developing autism. We know that seizure burden or refractory seizures, especially early in life, increase the risk of developing autism. We know that there's common genetics in both that can increase the risk of both. We know that family history also can increase the risk of both autism and epilepsy. And there's some studies that show that females may have an increased risk for epilepsy if they have autism. The reason I have the question mark there is because this is based on criteria where we thought that there's a lot more males diagnosed with autism than females, and the females that were diagnosed were typically the ones that had the lower IQ. We're finding now that autism can present in females with much higher IQ, and their presentation is slightly different. So a lot of the higher functioning females with autism have been missed, so they're not really included in the study. in all the studies. So we know that, so let's talk about the first risk, intellectual disability. So having a lower IQ increases your risk of epilepsy in autistic patients by 3 to 5 times. A big study by Dr. Ahmed and Sarah Spence looked at the epilepsy prevalence in kids who have autism and intellectual disability. It was 21.5%, whereas the prevalency of epilepsy in kids with autism who didn't have intellectual disability was only about 8%, still a lot higher than the general population. So we know that the presence of intellectual disability can influence the rate of epilepsy. And also conversely, the risk of autism in the epilepsy population is also higher when you have associated intellectual disability, and it's reported to be around 16%. So another big risk factor for both is early onset seizures. So we know that early onset seizures is a risk factor both for autism, but also for intellectual disability. And that's because early childhood is a critical phase in development of basic social, cognitive, and linguistic skills, which then are critical as the foundational skills to build other social skills, academic skills, and behaviors. And epilepsy in early life has very severe and long-lasting cognitive and social repercussions. And again, this is supported in epileptic encephalopathies. So, and the mechanism of this, oh, hold on a sec. All right, never mind. I was told that my background left me, but that's okay. You guys don't mind my office background, right? Okay, anyways, so I'm going to continue. So we know that early onset seizures will disrupt neuronal development and brain or neuronal connectivity. So when you have seizures early in life while the brain is still developing, it causes physiological and functional deficits in the hippocampus. It causes impairments in the synaptic organization between the brain cells. And in general, it causes interneuron dysfunction, which then throws off the inhibitory and the excitatory mechanism of the neurotransmitters that are critical in generating the seizures. And when you do that, you actually disrupt the cortical network. And these cortical networks are critical in the development of learning and being able to acquire new skills, developmental skills. So it leads to abnormal neural dysfunction, which then increases your susceptibility to neurodevelopmental disorders and autism. And I love the schematic. This is from an old article from the 90s, and it really shows you the critical part of how quickly the brain makes connections and what a quick rate the brain makes those connections in the first 2 years of life. So the first column is the newborn, where there's not as many connections, then 1 month of age, then 6 months of age, and then by 2 years of age, that's what it looks like. All these connections and branches of connectivity are being made. So you can imagine if there's seizures that disrupt this pattern, that it can definitely impact your development and long-term outcome. So, and this is again strongly supported and already been studied and validated by us understanding about the epileptic encephalopathies that are associated with early life seizures. So what are epileptic encephalopathies? They're characterized by epileptiform abnormalities that are associated with progressive brain dysfunction, which then causes cognitive and behavioral issues, and they actually have epileptic seizures. And the ILLE classifies them, and these are just a few of many that are out there. West syndrome is considered as one. Dravet syndrome is considered as one. Lennox-Gastaut, Landau-Kleffner syndrome, and epilepsy with CSWS or with ESES, which is electrographic status epilepticus of sleep. We're going to talk about all of these in a little bit. So what is West syndrome? As many of you are already familiar with it. It's a combination of the presence of infantile spasms, specific finding on the EEG called hypsarrhythmia, and associated with significant developmental regression. And these loss of skills are permanent and strongly associated with the presence of the hypsarrhythmia or the abnormality on the EEG. So early interventions and treatment is key to helping long-term development. Now, West syndrome can be caused by a lot of different underlying etiologies or disorders. One of the more common ones that's associated with West syndrome is tuberous sclerosis complex. And in tuberous sclerosis complex, the risk of autism is way higher if those kids present with infantile spasms during the first year of life. Up to 70% of those kids will later develop autism. So if you have a child with tuberous sclerosis complex that's had spasms early in life, you really got to monitor them for autism. And but there's also studies that show that the presence of spasms, regardless of what the underlying cause of the spasms are, will also increase the risk of autism. So it's critical to control the spasms and the hypsarrhythmia. We also have Dravet syndrome, which is a sodium channel mutation and encodes voltage gauges. Sodium channels are expressed in the brain, and these are responsible for the generation of action potentials and the neurotransmitter imbalances. 60% of these kids have autism, and of course the risk of autism is a lot higher in the kids who present with seizures before the age of 1. Again, supportive of how early life seizures can really lead to autism and other significant neurodevelopmental disorders. Lennox-Gastaut syndrome is a type of seizure that's a type of epileptic syndrome that's composed of many different types of seizures, including tonic seizures, atonic seizures, atypical absence. There's some specific EEG findings that go along with it, and there's multiple underlying etiologies that can give rise to LGS, including Dravet syndrome and West syndrome. And there's a very significant risk of autism in these kids if they start with the multiple seizure types before the age of 2. Other than that, it's about 30% of those kids will have autism. Okay, so that's it about the shared similarities in terms of shared outcomes with early life seizures. We also know that there's also genetic syndromes that have genetics that are present both in autism and epilepsy. So they have this shared genetics, these entities. And the reason we know this is because we've had such a huge breakthrough recently in our genetic testing, and so we're able to find a lot more abnormalities. And the interesting thing is that a lot of these genes that have been identified are strongly implicated in specific cellular pathways, especially in the GABAergic system, which is also strongly implicated in the epilepsy pathway. And GABA is one of our neurotransmitters that plays a critical role in the generation of seizures in epilepsy. And so what happens is it can lead to a disruption of the excitatory and inhibitory balance within the brain, which not only can lead to epilepsy, but really also leads to dysfunction of cognition. Some of these genetic syndromes that have both associated autism and epilepsy are Fragile X syndrome. It's the most common inherited form of intellectual disability in autism, and over 23% of these kiddos have epilepsy. Now, all of these estimates that I'm presenting is more likely an underestimate, but it's a minimum of, and that's because, not all the studies have been really consolidated or reviewed. Tuberous sclerosis complex, epilepsy is present in about 80 to 90% of them. Autism is present in at least 50% of those cases. Angelman syndrome is another one that has 85 to 100% of cases have epilepsy, and at least 40% of them also meet criteria for autism. MECP2 related disorders like Rett syndrome, all of them have the autism phenotype, and 50 to 90% of them also have epilepsy. Phelan-McDermott syndrome, which is another highly recognized syndrome now, which involves the SHANK3 gene mutation. 40% of those kiddos have epilepsy, and up to 90% have autism. Smith-Magenis syndrome is another genetic syndrome. 45% of them have epilepsy, and at least 90% have autism. So again, you'll see that there's overlap there too in terms of genes that predispose you to autism and epilepsy. So I really like the schematic because it kind of helps you understand that there could be two broad mechanisms contributing to the relationship between autism and epilepsy. One is that autism and epilepsy probably share a common biological pathway or etiology. So whatever underlying problem, genetic syndrome, or whatever there is giving rise both to the epilepsy and to the neurodevelopmental deficits, including social and cognition deficits. And we know from early life seizures that epilepsy itself can contribute to exacerbation or worsening of cognitive skills, both socially and intellectually. And so there's this relationship between the two that goes on and on and on and on and on. And so this means that controlling the seizures by themselves may not always alleviate your symptoms of neurodevelopmental delays or autism because of whatever underlying disorder you have. And so, or both could be in play. So I really like this visual because it kind of drives that point home. Okay, so how do we look for the shared biology between autism and epilepsy? Well, one of the main ways we do it is through genetic testing. We have lots of different ways of doing more quick and efficient genetic evaluations. One is looking through chromosomal microarray, which is fairly quick and easy, and most insurance plans now cover it if you have a diagnosis of autism. And another way that we can look for genetic underlying causes or shared biology is through more specific single gene defects or genetic testing that looks at certain genes that are implicated in epilepsy. And sometimes we refer that as the epilepsy gene panel that we can do. So it's critical to consider getting those done. So now we're going to jump to the comorbidities that exist between autism and epilepsy. And it's very interesting that they share the same comorbidities. I'm going to just focus on two of these. And one is ADHD and the other one is anxiety disorder. So we know that 30% of kids with epilepsy have ADHD. And again, that's probably an underestimate. And 70% of kids with autism have ADHD. So they both have that comorbidity. Medication treatment is not contraindicated in epilepsy, contrary to rumors out there or hearsay that maybe methylphenidate can worsen seizures. That's not true. It can improve quality of life. But medication treatment for ADHD and autism must be done with very careful consideration because most of the studies show that stimulant treatments are only beneficial in high-functioning autism. The kids that have lower functioning autism with associated intellectual disability don't do well with stimulants, so that's something to keep in mind. But in general, treatment can help quality of life in both. And of note, there is in the ADHD world, there are some studies looking at that are noting some EEG abnormalities in ADHD that are associated with ADHD. Anxiety disorder is present in both. In autism, there's been an explosion of research over the last 10 years saying, oh my gosh, you can have autism and meet criteria for anxiety disorder, and it's not just part of the autism. And the range is 11 to 84% of cases of autism can meet criteria for an actual anxiety disorder. A big study, which was a meta-analysis of 31 other studies, said that they found anxiety disorder or one specific anxiety disorder or some sort of generalized anxiety disorder in about 40% of cases. And also kids with autism, in general, the presence of autism increases your risk of anxiety and OCD, and it's 2 times higher than typically developing kids. And in the epilepsy community, anxiety disorders are the second most common comorbid psychiatric disorders, the first one being depression. And there's a lifetime risk of developing anxiety disorder in at least 22% of patients. It's probably even higher than that. And it tends to be, anxiety disorders tend to be more common in younger kids with epilepsy. Okay, and what are the treatments for anxiety? Both benefit from cognitive behavioral therapy. There's been, again, a lot of research out of UCLA with Dr. Wood's team supportive of cognitive behavioral therapy for anxiety and autism, CBT. And what CBT really is, it's a combination of behavioral therapy and cognitive techniques, whereas ABA, which is the treatment for autism, is just behavioral therapy. CBT is cognition and behavioral therapy, which means you have to change your cognitive construct first. So you have to do a lot of pre-teaching and help understand how you're thinking and then practice those skills through behavioral therapy. Okay, there's actually, believe it or not a lot of good studies supportive of using medication treatment for anxiety in younger children with autism. There's more studies validating their benefits when the kids are a little bit older, but we still use them, and there are cases that it's beneficial in. but cognitive behavioral therapies is extremely beneficial overall. And CBT is also used for anxiety and epilepsy. It's the first choice of treatment, followed by medication treatment. And oftentimes medication treatment is used to sort of increase or enhance the child's ability to learn from the CBT or to be able to be taught. Okay. So autism and epilepsy have similar comorbidities. The presence of autism and epilepsy also has been known to worsen those comorbidities, which is interesting. So we know that kids who have autism and epilepsy, they tend to have more, not just more symptoms of ADHD, but even stronger symptoms of ADHD. And another study to support this looked at over 2,600 kids with autism, and they found of those kids, the ones that had epilepsy, which is about 5% or so, had more severe behavioral symptoms. So the presence of epilepsy in autism itself makes the comorbidities worse, if that makes sense. And this can happen regardless of IQ. Okay, so now we're going to talk about another area that's commonly seen both in epilepsy and autism, and that's the presence of abnormal EEG discharges or epileptiform discharges. And there's a huge prevalence of this in our autism population, even if there's no actual clinical seizures. So the prevalence of abnormal EEG findings or discharges is up to about 60% in the autism population. And the prevalence of these abnormal EEG findings in the regular person is only about 1%. Some studies reported to be 5%. So it's definitely a lot more significant in the autism population. They tend to be seen more often, these abnormal EEG findings, in patients who have low IQ or intellectual disability. We definitely know that they're activated by sleep. And they tend to be seen more in patients who actually have clinical seizures, but you don't have to have clinical seizures to have these. And the first time we ever learned about this phenomenon of abnormal EEG discharges without necessarily, with or without clinical seizures, was in two syndromes that are sometimes considered as part of the epileptic encephalopathies as well. One is Landau-Kleffner syndrome, or non-convulsive status epilepticus of sleep. This disorder presents in a normally developing child until the age of 4 or so. So it starts after the age of 4, and suddenly the child has a huge developmental regression, specifically in their language skills. So they were verbal and suddenly they lost that ability. So it's associated not only with an expressive language impairment, but also receptive language impairment. And then they have a very specific finding on the EEG, and that is defined as electrographic status epilepticus of sleep, or ESES. And basically these are abnormal discharges in the front of the brain that's present in 80% of deep sleep. And this regression also creates an autism phenotype or characteristic. So they don't truly meet criteria for autism, because remember, autism, it has to be there since birth or by the age of 3. And so this is, when we see this case, we say it's just an autism phenotype. We can't really give the autism diagnosis. And the cool thing about this is that if you catch it, a big part of the kiddos improve. So 30% of cases completely resolve, their language returns, their behavior is normalized, 30% of cases don't respond, and about 30% of cases continue to get worse regardless of treatment. But there is some hope there. Another entity that's not necessarily associated with the classic 80% of abnormal discharges on the EEG is called continuous spike wave discharges in sleep. It's also associated with a pattern of some loss of skills, and it may or may not involve language. And again, these are things that we usually only see in sleep. And this is some examples of EEG patterns. So the one on the left side of my screen is a normal EEG pattern in a child. The one on the right side is an example of ESES, or continuous spike wave activities of sleep. And there's also other EEG abnormalities that sometimes we see that I just want to mention real quick, and that's just slowing of the background. And this is an example of slowing of the background. Okay, so what does it mean? What are the implications of these EEG abnormalities in autism? Well, a study was looking at over 100 kiddos, and these kiddos, and this is one of the few studies to date that actually use EEG data from an overnight sleep EEG. Most of the studies out there use EEG data that is just based on a 1-hour EEG. And so it's critical when you're looking for these things to get an overnight comprehensive EEG where you can capture all the stages of sleep. So this is one of the few studies that actually used overnight video EEG data. And they found that in over 100 kids with autism, 60% of them had epileptiform discharges, and another 22% of them had slowing of the EEG background. And when they isolated and looked for the EEG discharges in the autistic kids that actually had clinical seizures, they found that these epileptiform discharges that didn't necessarily go on to generate a seizure were present in 95% of those kiddos, compared to only 50% of kids with autism had the EEG discharges that didn't have clinical seizures. So then this led us since then to thinking, gosh, so does that mean that the presence of EEG abnormalities means earlier in life that it can increase your risk of having actual clinical seizures later in life? And so are the presence of EEG abnormalities in autism predictive of later onset epilepsy? So there's been a few studies looking at that now, and many studies do support, many studies do show that oftentimes the actual epilepsy onset occurs later in life. So oftentimes early in life, the epilepsy in autism prevalence is only about 7%, but the older the autistic kids get, the higher the risk of epilepsy. So the older they get, like in adolescence and early adulthood, the risk of epilepsy in them goes up to 35%. And a lot of these kiddos did show abnormal EEG findings earlier in the life on their EEG. And specifically one study that really looked at that showed that 73% of the kids that later developed epilepsy in life did have EEG abnormalities earlier in life. So if your child gets an overnight video EEG at the age of 5 or 6, and we as your doctors say, it's abnormal, we're not necessarily going to do anything about it, but we're going to monitor it, it means that your child is at a higher risk for developing seizures and epilepsy later, and you have to keep a close eye on that. Okay, so yes, likely the presence of EEG abnormalities may be predictive of later development of epilepsy and autism. Now, as I mentioned, the general population can have these EEG abnormalities, but that's not seen in the general population. Just because you have some abnormal discharges on your brain in a typically developing child that doesn't have autism or epilepsy does not mean they're going to have epilepsy later. So the data has not been supportive of that. Okay, so how can these EEG abnormalities impact brain and impact autism or development of autism? Do they have anything to do with the severity of developmental delays or autism? Well, we know that in animal studies, at least, when they found EEG abnormalities, also known as interictal discharges, meaning discharges between actual seizures, although a lot of people don't like that terminology because a lot of kids that have these discharges don't have seizures. So it's maybe better referred to as intermittent EEG discharges. But especially in the animal studies, if they occur in the prefrontal cortex and they occur early in life, that when you follow the animal models out, they do result in social deficits and behavioral changes, even once the discharges have gone away. So perhaps there's a critical time in development where the presence of those discharges can impact your future developmental skills and social cognitive skills. So this supports the idea that, again, early persistent epileptiform discharges can have long-lasting effects on synaptic plasticity and the cortical network of the brain, which then can lead to autism or autism deficits. Another thinking is, great, maybe they impact you earlier in life, but what if it's later in life? What happens then? Well, there's some evidence saying that maybe the EEG discharges cause some fleeting neurological changes or alterations in your consciousness and cause transient cognitive impairment. And that the TCI or those discharges that are causing transient cognitive impairment might have a big impact on your day-to-day life. I mean, you can imagine if you're having these discharges and you're briefly kind of, not fully there, it can maybe impact that. And in patients with epilepsy and this was also looked at in patients without autism in epilepsy, and they definitely supported that there can be a subtle cognitive impairment during the times of epilepsy-involving discharges, and up to 50% of patients that experience the discharges, and while they're doing assessments or cognitive testing, they do show transient impairment, but it can recover in those cases, especially if there's no autism. The other thinking is, well, could this be a cumulative effect? Does the cumulative effect of these discharges impact autism severity or autism development? Maybe. Another thought is, does the location of the discharges have an impact? If it's in the temporal lobe versus the frontal lobe, can it have an impact? Yes, maybe if the discharges are in the language areas or in the verbal functioning areas of the brain, that patient might have more language deficits. So definitely, persistent epileptiform discharges can influence cognitive behavioral outcome, and especially if those discharges occur early in life. And we know that there is an increased risk of autism with kids who just have epileptiform discharges under the age of 2. But this, again, hasn't been fully well studied. So discharges can have a detrimental effect on intrinsic connectivity networks of the brain, which can lead to abnormal neurocognitive development and social skills. Or the other thinking is, abnormal EEG discharges in some cases could just be a reflection of underlying brain dysfunction, like we see in epileptic encephalopathies. Remember that shared biology where a certain gene mutation or copy number variant or genetic syndrome gives rise to autism and epilepsy? Well, maybe that underlying disease also gives rise to these discharges. So all of these things can be at play. And that's why it's really important to know if your child has a genetic syndrome or a gene mutation that can predispose him or her to epilepsy and autism. The other thinking is, well, we know that these discharges are more frequent and most of the time occurring in sleep, not always, but they tend to be more frequent in sleep. And does that somehow impact your consolidation of memories that are a critical part of your deep sleep? And this is what the theory we think is under the regression that causes a regression in Landau-Kleffner syndrome. But again, we don't quite know exactly. And the other thought of it is, wait a minute, some kids have these EEG abnormal discharges and aren't as severely impacted as other kids. Well, there's a theory that then the vulnerability to EEG abnormalities may also play a role. That children who have maybe greater resistance to these discharges because they have a stronger network of cortical support won't have that clinical implication. And the thinking is, this is why in the general population, in a normally developing kid, if there are EEG discharges, those discharges are not as impactful or as severe in their impact on the child's development and outcome. Another thought was, well, could the presence of these EEG abnormalities be indicative of the severity of autism itself, or be indicative of autism symptoms? Could it reflect more severe autism core deficits? So one study looked at the presence of these epileptiform discharges, and they found that these discharges were more prevalent in lower functioning autistic kids. And we know that lower functioning autistic kids tend to have more behavioral issues, and they tend to have lower IQ compared to higher functioning kids, which are more functional and have less behavior. So these EEG discharges were found in about 60% of those kiddos that were lower functioning versus 20% of kiddos that were high functioning, meaning they had less behavioral issues. And we know that the presence of epileptiform discharges has been associated with a higher incidence of aggression based on questionnaires and more severe stereotypic behaviors or self-stimming behaviors. So, and it was 61% of kiddos that had more severe aggression and stimming behaviors had those discharges versus 36% of those kiddos. So again, there's strong correlations as well. So there's a very strong association between autism and these epileptiform discharges. In fact, a lot of people are now saying, oh, these are typical discharges that we see in autism. Yes, so we're sort of starting to think about it that way, but it doesn't mean it's normal, and it doesn't mean that it's not significant for something. So we should always monitor and keep an eye on it. But we know that there's no direct evidence that these abnormalities directly cause autism, but maybe impact the severity of the symptoms and the development of epilepsy later on. So the takeaway message again is make sure when you're doing an EEG, you do an overnight EEG to be able to capture the various stages of sleep. So now when we find EEG discharges, what do we do about them? Should we treat them? Should we not treat them? And this is very, very controversial. And there's been lots of studies that support both sides of the coin, whether you should treat it or not. So one of the largest studies was done by Dr. Shez in 2006, and his study showed that if you treat the EEG discharges with Depakote, there tends to be improvement in autism symptoms. And another study, a more recent one, a smaller study, looked at treating autistic kids with Keppra, and they thought that based on rating scales and behavioral checklists, there's an improvement in those kiddos. However, the other studies that kind of don't support this mention that, well, we know that Depakote is also a mood stabilizer, right? And could it be possible that the mood stabilization effects of the medication is what's helped the symptoms and not necessarily because the discharges went away, right? And we know that oftentimes these discharges go away on their own, regardless of treatment. So that's something to keep in mind. And a lot of the studies that are in favor of treating the discharges don't account for, well, did the child also have ABA at the time? Did the child also suddenly get more support in school? So could the improvements be from those additive treatments rather than just from the medication? So they didn't control for that. So it's not a completely reliable outcome. Either way, despite the limitations of the studies to date that we don't have a lot of evidence one way or another, we know that the presence of EEG abnormalities can be associated with cognitive and behavioral issues in children with autism. And whether the child that we see the EEG abnormality on, regardless of the presence of seizures or epileptic seizures, needs to be treated or not, really it needs to be decided on a case-by-case basis. So you have to look at the severity of the EEG abnormalities. For example, if the child's brain is having EEG abnormalities and it's happening more than 50% of the time in their sleep, I usually treat. Okay, what if it's only happening 20% of the time? Also, the location of the EEG abnormalities can help make that decision of whether to treat or not. Is it happening in the frontal lobe, where we know the language centers are, or in the temporal lobe, where we know the social cognition, a lot of that occurs. You also have to look at the overall cognitive and behavioral issues at the time of the child, where certainly the child is in a time in their development where they're having more difficult attention or executive functioning skills. Maybe the discharges are impacting that. And also you have to take into consideration the risk and benefits of using an anti-epileptic drug to treat it. So it really, you don't just write it off. You really have to look at the big picture, and you have to take the whole child into consideration when deciding to treat those discharges or not. And I'm just going to mention this very quickly. There's something known that has been discussed out there called the regressive type of autism, and this has been talked about for a very long time, where about a third of kids with autism supposedly have a big regression before the age of 3. But all of those kids were never normal to begin with. So those kids had some delay. So those kids had some speech delay. And maybe by the age of 2, instead of having hundreds of words like they should, maybe they only have 20 or 30 words. And around the age of 2, they regress and lose those words. And so the thinking was, gosh, could this be a group of a population that the EEG abnormalities are maybe directly resulting in the regression? The study results have been mixed so far. And the problem is, again, we don't have a lot of studies that can catch those kids when they're regressing to do an overnight video EEG study. First of all, not everybody has access to an overnight video EEG study. And second of all, we often as epilepsy doctors or neurologists don't get the referrals in time. So the child regresses and then the referral doesn't come to us in time to do the EEG. And by the time we do the overnight EEG, the symptoms have improved. But it's unclear. It's unclear. So far, the data doesn't look like at the time of the EEG, there's abnormal EEG discharges, but maybe we missed the window. Who knows? Nevertheless, it's important to identify any case of regression, because if we find something on the EEG like LKS or CSWS, it can potentially be treated. So it's really, really important, again, to get an overnight video EEG study when you get an EEG. So I'm going to wrap things up for us real quick, and then we can answer questions. So we know that autism and epilepsy are strongly related. Both are now considered spectrum disorders. Both impact social cognition. Social cognition deficits and autism are strongly associated with epilepsy and autism. And identifying the presence of social cognition deficits in epilepsy care, it's critical, because that means you can start early interventions and increase your potential for improving. The co-occurrence of both epilepsy and autism might be an indication of an underlying shared biological mechanism or an underlying shared genetic susceptibility or genetic syndrome. And specifically, seizures in the first year of life predispose children to later developing autism. They are much, much higher risk. The presence of intellectual disability increases the risk of both, as we see that the risk of autism is highest in the epileptic encephalopathies. Autism and epilepsy also share a lot of comorbidities like ADHD and anxiety. And so it's important to also monitor for that. Implementation of behavioral, educational, and communication support services early on in life, along with medication for treating the seizures, are important and needs to be a very comprehensive part of managing epilepsy as a whole. Epileptiform discharges or abnormalities, regardless of actual clinical seizures, may play a role in development of autism, autistic features, or regression. And we see those discharges more often in kids with actual clinical seizures and autism than we do with just autism, but it is still more prevalent than the general population. So moving forward, what should you always want to think about and do, both as a provider and a parent? It's really important to get genetic testing. It's important that when you do an EEG, you do an overnight video EEG study. It's very important to screen for social cognitive deficits and autism and start early interventions as soon as you can. And it's really important to monitor and treat comorbidities that can impact developmental progress, like the presence of ADHD or anxiety. Future goals of research. We definitely need more research understanding the role that the EEG abnormalities play on autism and autism severity, and if this should be treated or not. And everybody's still working hard on trying to identify biomarkers that can help red flag patients that are more vulnerable to autism or social cognitive deficits. All right, that's it. So now we have 5 minutes or so left, and I'm open to questions. I'm going to stop share. Okay. All right. I'm not sure how we are managing questions, but I'll give you guys a few minutes. I know this was a lot of information to take in less than an hour, but let me know if you guys have any questions. Okay, hi, yes, question.
I just wanted to thank you so much for your wonderful information. My grandson visits you, and
Oh, great.
we appreciate your knowledge, and thank you.
Of course. Oh, thank you for being here and listening in these tough times.
Thank you.
Anybody else with questions? Yes. I have Ayala 5. Is there a question?
Oh, me?
Yes. No, no question?
Well, no, but I'm 20. My mom, I have seizures, but I don't feel them.
Okay.
Like when I have one, it just comes, but I don't like feel no seizures. So my mom, I have the VNS from the magnet
Okay.
on me, and my parents are always here with me, so I'm like here at home and they take care of me.
Awesome.
When I have a seizure, they just put the magnet on me.
Awesome.
Thank you.
You're welcome. Everybody, please be safe. Please wear your mask and
Yeah.
please vote.